lung cancer care is complex. There are many different steps involved, from the initial point of identification of a nodule or a lesion in the lung that could be a lung cancer, all the way to treatment and the outcomes that you get. So the steps in between involve a diagnosis, a tissue diagnosis, and then staging procedures, which involve certain radiologic testing and can also involve a staging biopsy. And then, of course, we have the treatment options that depend on the stage. So the earlier the stage for non-small cell lung cancer, the more likely you are to involve surgery. The later the stage, the more likely you are to involve radiation therapy, chemotherapy, and palliative treatments. And of course, at the end, you get outcomes. So the interesting thing is that each of these steps has a widening array of options, and each of these options is driven by a physician in a specialty. And the complexity of lung cancer involves the fact that these specialists, if we are not careful, work as if the challenge is uniquely theirs, whereas the challenge really is much broader than any one specialty has. So what we have to do, therefore, is engage the full range of specialists so that the care that an individual patient gets is based on the care they need, rather than the care that the provider knows how to give. So we get to the answer to your question. How do you measure the effectiveness of this interdisciplinary interaction? And the answer is you need objective measures that have bearing on the perspective that is important. So the perspectives, of course, are those of the patient and his caregiver, but also those of the people who have to pay for the care delivered, and those of the perspectives of those who have to create the environment of care, and the perspectives of the various experts involved. So, for example, the ultimate benchmark, of course, is survival. For a cancer that is lethal, the likelihood of survival is something that we need to be able to compare. Is it higher when you deliver care within an interdisciplinary environment or outside of it? The other benchmarks involve patient perspectives. How satisfied, happy with the care they got are the patients and their caregivers. But things like the processes of care. How thoroughly are you staging your patients within your program is a key measure of the success of your program. How much time does it take you from initial onset to the actual completion of care is another benchmark. We have also looked at things like when you have a multidisciplinary environment, for each individual patient, of course, there are decisions that that group has to make. And one benchmark, a critical benchmark really, is when you make those decisions, how frequently do you actually carry them out? Assuming that those decisions are the best recommendation for an individual patient, how frequently do you actually carry out that decision? That best recommendation is another way of measuring this interdisciplinary interaction. Yes, I think the Chinese need is actually not unique to China. It's a universal need. So if you look at multidisciplinary care, it's something that makes a lot of sense. It seems logical for all the reasons I just talked about. Many different actors, complex disease, patients have high needs, and so on. But the reality is there are lots of things in medicine that sound sensible, but when you measure or test them, you find out they don't actually turn out the way you thought. So one of the things that we do need to do is to rigorously measure. When we say we're doing multidisciplinary care, we need to measure what exactly are we doing, what are we getting out of it, and who is benefiting or not benefiting from that. So what you just said about the Chinese need is actually not unique to China. In the United States, one of the things that we have been saying is we can't just assume because we're getting together that we're benefiting the patient or making things better. What we have to do is prove it. And that's where there is still tremendous opportunity for us to design rational studies that can help us better understand what we're doing when it works and what we're doing when it does not work. Staging is a vital component of any oncologic care, especially lung cancer. The staging system does many things for us at the same time. It serves us as a common language. So when I say a patient is T2N1M0 and I say it in English, my colleague in China, in Japan, in North Korea, in any part of Africa has immediately the same mental picture of who this patient is and what's going on with them as I have when I use that term. So the staging system is a common language for us. It's a universal language, and we have to speak it fluently. We have to understand it, its grammar, its alphabet, okay? The components of it. When I say somebody's a T1 or T2, when I say somebody's a T1A, T1B, T1C, I have to be clear in my mind of what I mean, and the person listening to me also needs to have exactly the same clarity of what I mean. So the language is one. But the TNM system also serves us as a prognostic measure. It gives us a working idea of how much risk the patient we're talking about is faced with. And it also gives us a good idea of what the range of management options for this individual patient will be and what the likely outcomes for that patient will be. So these are two or three very important things that the TNM staging system does for us. The other thing it does, though, that we need to highlight also is it is also our pathway to progress. Because when we do clinical trials of novel diagnostics, staging, treatment modalities, those modalities have to be tested in clinical trials. And the clinical trials, to be successful, have to have comparable groups of patients in them. And that's where the staging system becomes critical for us. And not only is it the staging system, but the part that we have spent a lot of time and effort trying to highlight is that the staging, the thoroughness with which we investigate stage has a major role in outcomes. So when we don't apply the TNM staging modalities thoroughly enough, and we call a patient a stage which in reality is the wrong stage, the danger we have then is the patient may well be exposed to the wrong type of treatment that may be too much for him or her or too little for what he or she needs to survive their cancer or to do better with their cancer. So misstaging is a major problem when we don't investigate carefully enough. And then, of course, there is the danger that when we don't apply the staging system correctly and we are, say, enrolling patients into clinical trials, then the big risk is that you begin to put different groups of patients with differing risk into groups that you want to compare. And therefore, you may have asymmetric groups of patient risks on your clinical trial that can lead to results that are different than what they actually should have been. So for all these reasons, my research team has been very interested in trying to raise the universal quality of staging across the board, recognizing that once again, these multidisciplinary groups of people, the pathologists, for example, as one discipline, the surgeons, the pulmonologists, the people who get the material that we use to stage patients with, have a major role, and we need to make sure that the quality of the effort that they give to get us the correct stage for each individual patient is high, uniformly high. The great thing about the last few editions of TNM is that they are more and more evidence-based. And the key evidence is survival. So we've got these huge databases that the IASLC has now put together that is increasingly more international, that has patient details and outcomes information from many different countries. And that is now what is being used to figure out the prognostic implications of the varying types of tumor sizes, lymph node involvement, metastatic sites, and increasingly molecular things that we will use in future. The problem, of course, is as we have identified the differences of different types of, say, tumor sizes, different types of tumor histologies on survival, the staging system is becoming more and more complex. So the good news is that we're able to fine-tune patient risk based on subtle differences in characteristics. Like there's a difference between a patient who has a tumor of 2 centimeters than one whose tumor is 4 centimeters, for example, and trying to account for that difference is a laudable goal. The problem, of course, is that the more you finely split the staging parameters, the harder it is for people to remember how to do it correctly. And the more complex the staging system is, the harder it'll be to correctly apply it. And so what the big challenge we have is to balance between those two needs, to have a high degree of specificity of risk characterization or prognostication, but also to counterbalance with simplicity and user friendliness. So that is one huge barrier. The other barrier we have, of course, is this explosion in our understanding of lung cancer biology and understanding the molecular predictors of patient outcomes. Now, the TNM system is currently a purely anatomic system. It's based on tumor size and location, lymph node number and location. It's based on sites of metastasis. But now with our expanding understanding of cancer biology, our expanding array of measures of microscopic presence of cancer, such as circulating tumor cells, and even beyond that, cell-free tumor DNA or circulating tumor DNA technology now available, how are we going to incorporate some of these really cutting-edge diagnostics and biologic prognosticating ability into what is a traditionally anatomy-centered staging system, the tumor node metastasis or TNM staging system, is another major challenge that we are going to be facing over the next couple of decades. I think the first challenge is to find a way to communicate better. Lung cancer is a complex disease. Our ability to successfully intervene to salvage life and quality of life is rapidly expanding, and that rapid improvement requires a lot of knowledge, which is increasingly specialized. So what we have to do is bring that knowledge readily available at the point of care, which requires information, information technology and understanding of how to bring that information right to the point where it is needed for the patient's benefit. So this is where media becomes extremely important for us. Our communication systems, whether it be print media or electronic media. What we have to do is bring knowledge right to the point of the provider where he can reach for it. So part of what that requires us to do is actually to accept the need to externalize that knowledge. We can't expect every provider to know everything that's out there for every patient. You can't memorize, because if you tried, you're destined to fail, because the field is expanding exponentially. Our human memory capacity is not nearly ever going to be enough to meet this challenge. So what we have to do is encapsulate that knowledge into a format that people can reach into as they need it. I think that's where information technology becomes extremely important. One of the key movements in all of medical care, all of oncology, and increasingly more and more of lung cancer care is the patient's perspective, patient-centeredness, okay? Things that benefit our patients need to be regarded with a higher level of importance. And one of the things that we are learning from patients is not only is there a need for better survival as a primary outcome for a lethal disease, but the toxicity of our treatments also is very important. And that toxicity runs the full spectrum of care, from, yes, conventionally chemotherapy, the toxicity of chemotherapy, whether it's conventional toxic, cytotoxic chemotherapy, to at the other extreme, oral targeted therapies. But also at the early end of the spectrum, the toxicity of our surgery, the toxicity of our radiation modalities. Okay. So the difference between an open thoracotomy and a minimally invasive surgical resection procedure may not be a difference of survival, but it is clearly a difference of patient comfort, pain, length of stay in the hospital, and the duration of recovery required. So minimally invasive resection procedures, but also minimally invasive staging procedures, let's not forget, are significantly more patient-friendly than some of the more traditional resection and staging procedures. So, given a choice between a large posterolateral thoracotomy with a rib-sparing approach to deliver a tumor that requires several days in the hospital post-operative recovery versus a VATS or a robotically assisted procedure with multiple ports and small incisions, no rib spreading, and therefore consequently significantly less post-operative pain, shorter post-operative recovery, to, yes, where the facility exists, both the human capability and the technological capability to do single port approaches, absolutely, to the degree that such approaches are less toxic to the patient, is the degree to which they will be more valuable to our patients. For trainees, as much as possible, to be exposed to the range of expertise. There are patients who have to have an open thoracotomy because of unique characteristics about their tumor. So I think it's important for young emerging trainees to be exposed to the full range of techniques and capabilities that exist. And the ideal would be, once again, to have the full range of knowledge available, so that then what drives what gets done for an individual patient is not the limitation of the doctor or the surgeon's knowledge or expertise, but rather the unique characteristics of the patient's cancer and the patient's needs. So have the patient, about whom all of this needs to be anyway in the first place, be the key driver of what we do. And for that to truly happen, what we as clinicians need to have is some access to the full range of capability. And this loops back to multidisciplinary or interdisciplinary decision making as well. So the ideal would be there is a patient with a lung cancer, and we look at the full range of who the patient is, what his past health has been, what the cancer is, what the cancer needs. And then once we have decided objectively what is best for this individual patient, we now figure out who has the requisite range of skill sets that can deliver that care. And we match that provider up directly with that unique patient, so that it's the patient's needs that now drive the provider's selection, rather than the provider's capability driving what the patient gets. I have said several things already. I have said a lot about the complexity and the emerging expansion of that complexity over time. The diversity of knowledge, of capacity and capability that we have to have for our patients. And I have said how impossible it would be for any one individual clinician or group of clinicians to have access in person to that full range of knowledge. So that brings you to the point about communication and encapsulating information right at the point of service. Who is going to provide that? It is companies like AMA that provide access to knowledge, information, wisdom that the care providers have to have readily available at their fingertips. So the old style of memorizing knowledge so that you have it available to you will not work anymore. What we have to do is rely on external capsules of knowledge that we can plug in when we need them. And that's where AME comes in. AME comes in helping us encapsulate that knowledge into formats that will be well readily accessible to us, providing a link between the creators of that knowledge and the consumers of that knowledge, and also providing platforms within which these groups of providers, creators of the knowledge, consumers of the knowledge can come together to meet in order to do the better outcome of care for our patients. So AME is extremely vital to this process, and it has been a pleasure for me to work with you guys. China is a country of major concern to any lung cancer expert with a population-based understanding of lung cancer and interest in lung cancer outcomes for several reasons. Not only do you have the huge Chinese population, but what you have is the emerging epidemic of lung cancer that a lot of us have predicted will be in the Chinese population because of the still widespread adoption of smoking and other risk factors for lung cancer. And so building up the Chinese lung cancer care infrastructure, lung cancer research infrastructure has to be of major global concern. And the IASLC, for example, is focusing more and more on the Chinese population for that reason. If you look at the worldwide epidemiology of lung cancer, you have to recognize that China has got to be a country of major interest. And building up the knowledge of the unique aspects of lung cancer, both the biology of the disease, but also the unique challenges of the healthcare infrastructure and access to high quality care, is something that is very important. Building up the knowledge base within China, the technical know-how to understand the nature of this challenge and to bring correct effort to overcome the challenge has got to be something that we are all interested in worldwide. So therefore, bridging the gap between Chinese experts, both clinical experts, research experts, whether it's clinical research or basic science or translational research, or even epidemiologic public health research, within China with the experts outside of China has got to be something we're all interested in. And therefore, I think these efforts that the journals, both the Translational Lung Cancer Research and the Journal of Thoracic Diseases, are making in that direction have to be of major interest to all of us.